Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat webinar. This evening, we are going to talk about racial ethnic differences in infant skin barrier and the use of skincare to promote a healthy barrier. As speakers, we have Dr. Candace Heath, who's Assistant Professor of Dermatology, Lewis Katz School of Medicine, Temple University, Philadelphia, Pennsylvania. We also have Dr. Lauren Schachner, who is a Professor and Chair Emeritus of Dermatology, Director of the Division of Pediatric Dermatology, Professor, Department of Pediatrics, Leonard M. Miller School of Medicine at the University of Miami, and Dr. Heather Woolery-Lloyd, Director of Skin of Color Division, Dr. Philip Frost, Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine. We'd like to thank our sponsor, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit a question using the question chat pane on the right-hand side of your screen. At the end of this webinar, our survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill in the survey, and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance and the recording of this webinar will also be sent to you. Again, if you want to submit questions to our faculty, please submit your question using the question chat pane on the right-hand side of the screen, and I wrote a little note there so you could see where you need to type in your question. So without further ado, I will pass the floor virtually to Dr. Lauren Schachner.
Good evening. Let's see if we get the slides going.
Oh, you're going backwards. There we go. Oh, polling question number 1. So we have polling question number 1. And if the audience could vote.
Are you moving them forward for the poll?
Yes, the polling question is open right now.
And can you move it forward to the answers?
And we're going to show the results now.
Excellent. So we'll get to talk this evening about the Atopic March, and it is the progression of early and severe atopic dermatitis issues to include respiratory disease like reactive airway disease and upper respiratory infections. I'm really pleased to be working with 2 distinguished colleagues this evening, going over skin barrier challenges of skin color newborns and infants. It's a subject we've worked hard on in recent years, and these are 2 papers done with pediatric dermatologists, pediatricians, dermatologists, basic scientists. The first published about 2 years ago is a consensus about the importance of ceramide-containing skincare for normal and sensitive skin conditions in neonates and infants. I had the pleasure of doing this both in North America and Europe, as you'll see later, and we have reached consensus that it is important to start ceramide-containing skincare for neonates and infants, both with normal and atopic skin. The second was the same group working on an algorithm for skincare for neonates and infants, and we'll share that with you as well. The algorithm, which covered all neonates and infants, if you notice in skincare tips, talks about full body moisturizing, and the group agreed that ceramide-containing moisturizers are preferred for reasons that we'll go into. As you can see, the algorithm talked about 3 common conditions: scaling, erythema, erosion, blistering. And in both scaling and erythema, part of the algorithm was moisturization. And then we go on what to do if the kid is getting better or not. and it's a really nice, simple algorithm. The challenges in treating skin of color patients in pediatric dermatology are myriad, and I think it's shared with, in many ways, with the older skin of color patients. There's often undertreatment and overtreatment because either inflammation can be mistaken for hyperpigmentation, or cirrhosis and hyperpigmentation can be mistaken for inflammation. So I see patients get undertreated when they need significant treatment and overtreated sometimes when they don't, when really they just have post-inflammatory changes and dryness. So my third bullet says lay on the hands. It's one way to tell whether the skin is inflamed or not. In skin of color patients gives us another sense to work with, and it's a good one to help us make the right decision. There are a lot of psychosocial challenges in richly pigmented skin from pigmentary abnormalities that we'll explore tonight. And I think it's important that the dermatologists who provide care to patients have to understand that skin of color, skin disorders won't always look and behave like the same condition in Caucasians, and we will move to targeted therapy most appropriate for Asian, Black, Latin skin, as well as Caucasian. So let's start in the beginning. In the beginning, when we're in gestation, it takes about 37 weeks for the fetal stratum corneum to be mature. But after we're born, it's going to take another 2 to 4 years before the stratum corneum and the epidermis reaches the maturity of adult skin. Here's a population in this paper of East Asian babies, 3 months to 24 months of age, and adults. And they were compared for several important issues that are in skin of babies. Transepidermal water loss rates higher in infants. Stratum corneum and the suprapapillary epidermis significantly thinner, about a third thinner in infant skin. And increased caseolytic, proteolytic activity in the stratum corneum gives increased desquamation and a yet thinner stratum corneum and more challenges for the barrier function. If we want to have an in-depth look at the scorecard between infants and adults, you'll see that infant skin is thinner, the cells are less detached, the DE junction flatter, easier to penetrate through for toxins and for antigens. There are less lipids, less melanin, less sweat, less moisturizing factor, but a higher pH, which is not good because that does not favor commensal bacteria. There's also, from a functional difference, decreased defense proteins, including cathelicidins and defensins in infants versus adults. And while the microbiome is similar in its makeup, the quantity of the different bacteria are much different between the adult and the baby. This is a slide from a paper that came out several years ago that looked at Black skin, Caucasian skin, and Asian skin. You can see, and not every study agrees with all elements, but it seems to be factual that ceramide levels are decreased in richly pigmented Black skin, and so the barrier function is challenged. And those patients, especially the atopic patients, often complain of pruritus and chronicity, and I think that's because the ceramide levels are down, among other issues. The water content is also down, allowing for dryness. Asian skin has a lot of ceramide in it, but it loses a lot of water. And if we do tape stripping and then challenge the skin, it's much more sensitive and reactive than Caucasian or Black skin. And Asian atopics, for example, have a lot of complaints of pruritus and many more visits a year than Caucasians would for the skin problem. Nice research has been done on the maturation of skin, and we see that the skin surface acidification begins shortly after birth, and hydration changes take place as well shortly after birth, but it takes a longer time for skin thickness changes to take place. And according to the Spurt by Fleur, on the thickness of skin and stratum corneum in babies, it takes 2 to 4 years before the baby skin barrier is as mature as an adult's would be. The pH in babies starts out rather alkaline, 6.3 to 7.5. It may be because the baby's been immersed in alkaline amniotic fluid for much of the preborn life, but we need to acidify. And the process of skin acidification is important in barrier maturation and in the activation of enzymes involved in the extracellular process of the essential stratum corneum lipids. And acidification also helps allow for a commensurate bacterial growth on the skin. So newborns and infants are susceptible to barrier disruption for myriad reasons, including higher pH, lower moisturizing factor lipids, and a thinner stratum corneum. And that allows for a higher transepidermal water loss and problems in hydration. But if you note a newborn skin looks pretty good considering they've been in this alkaline brine, and largely because of the vernix caseosa. This is a lipid and ceramide-rich fetal coating, mainly gets composed in the 3rd trimester of corneocytes and lipids, and it waterproofs the baby in utero. So newborn baby skin looks pretty good. The vernix caseosa can also have a protective function in the immediate hours and days after birth. While many people think, wow, it's neat to kind of scrub a newborn baby so they're all pink and clean, often nurseries are allowing several hours to days for the vernix to remove naturally, because the vernix layer increases hydration, suppleness, and plasticity of the stratum corneum, and it also decreases the surface pH, which, as we said, facilitates commensal bacterial growth and protects against pathogens. Now, all newborns and infants with atopic dermatitis should have appropriate moisturization in early infancy as part of their daily management. We can get a good consensus on that. We know that the lipids are a very important component of this envelope on top of the stratum corneum and the bilayered lipid mortar that goes between the bricks that are the corneocytes. And the cornified lipid envelope and the bilayered lipid layer are crucial elements for the barrier to function. And we need the barrier, this little stratum, thin stratum corneum, to prevent antigens, toxins, bacteria, irritants from getting into the skin. Now, the composition of lipids in the vernix and stratum corneum are very varied. The vernix has a good 20% ceramides, but the postnatal stratum corneum is made up of 40 to 50% ceramides. So it's a very essential component. And what happens if it's not there? Well, many skin barriers disorders in neonates and infants are characterized by a decreased ceramide content. And without the proper ratio, the stratum corneum becomes incompetent, and we see barrier dysfunction leading to dryness, irritation, erythema, itching, and in fact, atopic dermatitis, cirrhosis, ichthyosis conditions all feature decreased ceramides. And that brings us to the atopic march. The atopic march is when a patient with early onset atopic dermatitis, usually with an early onset, a positive family history, and a greater degree of severity, go on to have respiratory problems such as reactive airway disease, asthma with wheezing, sinusitis, rhinitis, polyps, and even food disorders. Well, what would happen if we could identify those early onset atopic patients and do something that might help move them to the track of a healthy child and a healthy adolescence? I submit to you that the early use of appropriate emollients could attenuate the severity of AD, could delay the onset of AD, and could quite possibly help us avoid the atopic march in as many kids who take that unfortunate march. And that was some nice work by Alan Irvine. Some other really nice work out of the United Kingdom looks at a big population. These are 1,900 random children enrolled. Transepidermal water loss is measured in them at 2 days and 6 months, and is seen back over a several-year period. So about 18% of these kids were atopic at 6 months. And the researchers found that those kids who had an elevated transepidermal water loss at 2 days was statistically significantly more likely to go on to clinical AD. So early intervention with liberal use of sophisticated emollients might attenuate such a march towards atopic dermatitis and eventually the atopic march. We said in the newborn that the original ceramide, the genius Homo, is 200,000 years old and sapiens is 70,000 years. Babies have been covered with a ceramide in the vernix caseoso since the onset of the human race. And the atopic dermatology guidelines published in the AAD support that, shows that evidence-based guidelines for atopic dermatitis support the use of moisturizers for skin hydration and for symptom improvement. And the guideline recommends moisturizers be used as a primary treatment for very mild disease and in conjunction with other agents as the disease becomes more severe. Well, the ceramides in the lipid bilayer of the stratum corneum play an essential role in regulating transepidermal water loss, which is a problem by 2 days of age, and maintaining skin barrier function. Skin barrier dysfunction, as we've said, can result in ceramide depletion, reduced skin capacity to retain moisture, and conditions such as atopic dermatitis. So this study out of Scandinavia looked at 6-week-olds, about 56 of them, and it looked at them at 6 weeks for kids who had a little bit of xerosis. And half the kids had an oil regimen and facial moisturizer regimen, and half didn't. Those who got the moisturization and the oil-based treatment, 75% of them had normal skin at 6 months, as opposed to only 37% who had normal skin. So really, twice as many kids in the emollient group appeared normal at 6 months. So it appeared that regular oil baths and moisturizing infants did seem to reduce xerosis, and possibly in this group, the advent of early atopic dermatitis, which is associated with the atopic march. This study by Lowe, also in Britain, looked at twice daily applications of ceramide emollients in the first 6 months of life. And they found that children who developed food sensitization had a later initiation of what was planned as an atopic dermatitis treatment. So the later you initiated the emollients, the more likely you would get food sensitization. Twice daily use of ceramides may prevent the development of food sensitization better than the daily use of more petrolatum and paraffin used emollients, as you'll see in some literature that I show. Paper by Simpson looking at US and UK babies. Now, these were all babies who were from atopic dermatitis families. So they were high risk. The parents, a sibling, had atopic dermatitis. So a group was started on emollients and a group wasn't. At 6 months, the group that had emollients were only half as likely to have developed AT as the control group, a 50% reduction. A similar study, 6 to 8 months in this case, was done in Japan by Haramukai, and he found that 47% of kids without emollients who were atopic prone developed atopy, as opposed to 32%. So out now to 6 to 8 months of an apparent protective factor. And has this been found by everybody? No. In some recent studies, one called the BEAT study, published in Lancet, they did a different type of study looking at about 1,400 high-risk kids. And the use of moisturizers did not reduce the risk of food allergy or AD. chiefly when measured at 1 to 2 years of age. Now, the study had a lot of work and a lot of sophistication, even some of the authors of some of the previous papers. But my problem with the study is that kids were allowed to get emollients as infrequently as once a day, 3 times a week, which I don't think any of us would do in our atopic patients. And the compliance rate was about 51%. Even the authors concluded that while these results appear non-confirmatory of all those other studies I showed you, the use of emollient formulations that are more sophisticated with ceramides might have a different effect. And of course, treating twice a day would have a different effect than once 3 or 4 times a week. Working with that European group I mentioned before, we concluded that the skincare of newborns and infants should optimize the stratum corneum's lipid and water content and exclude agents that could negatively impact the skin barrier. Ceramide-containing skincare supports stratum corneum hemostasis. Gentle cleanses and topical applications of physiological lipids can improve permeability, barrier homeostasis, and been useful in cutaneous disorders. And that's concluded by Lowe, who did that food sensitivity study, as well as an atopic study in that population. Parents and caregivers need to understand how to avoid irritating infant skin, whether normal or atopic. Soaps are out. Soaps are alkaline. Their pH would be 8 to 10, and they do not support a healthy barrier, anything but. We need to get an acid mantle, and cleanses close to physiological skin pH 4 to 6 are far preferable to accomplish that. So what does the ideal moisturizer have? It has to be safe, has to be effective, has to be near physiological 4 to 6 pH, free of additives, fragrances, and sensitizing agents, pleasant to use, and should improve the lipid and water content of the stratum corneum. And we're going to see some studies that look at this as I turn this over to my colleagues, Dr. Heath and Dr. Woolery Lloyd. So without further ado, I'm going to introduce my colleague, Dr. Candace Heath, Assistant Professor of Dermatology at Temple, to take you.
Thank you so much for having me tonight. And the next several slides are going to really be a nice segue to what Dr. Schachner's already talked about. He focused more on moisturizing and the benefits for the skin. And now I'm going to dive into some of the skin cleansing data. So let's get started. So polling question. On average, all skin tones have the same amount of ceramides. Is this question true or false? Unfortunately, I don't have the Jeopardy music. I wish I did, but I don't. So quickly put in your answer. Okay. So false, absolutely. So I agree with the majority of the group that that is a false statement, and we will learn more about that throughout the course of our program today. Okay, so, all right, there we are. So racial and ethnic differences in both newborn and infant skin barrier definitely can impact some of the things that we will talk about today. One of the things that Dr. Schachner touched on was to actually determine, is there any impact on atopic dermatitis when it comes to both cleansing, moisturizing the skin, and also any racial and ethnic differences. So in order to tackle this topic, to dive through the literature and find out exactly what an expert group thought about this data, this is a poster that came out of that experience. So a group got together, dived through the literature, including me, diving through the literature, looking at papers that really described changes or differences, even subtle differences in the skin in infants and newborns who had various skin tones. And these are some of the things that we were able to see. Now, of course, This slide is a little bit busy, but I'm going to really in the next couple of slides break it down and really talk about some of the take-home points from this literature review that you can take home with you. So this poster was actually presented at the SCALE conference. And really, we know that possibly skin sensitivity and also rates of xerosis, those things may vary from child to child, depending on their ethnic differences. And some of those differences can actually be found in the skin barrier. Also, are there clinical implications to these differences? Well, that one was really a complicated question for us to answer. And basically the conclusion was we really do need more data in order to prove an absolute that some absolute minor changes in the skin can have clinical implications. But as we go through the data, you can make a judgment for yourself about what you believe, and hopefully you would come up with some of the same conclusion statements that we did, and we'll also go over that as well. Definitely important is going to be cultural differences and cultural practices having an impact on your skin, on your patient's skin. So definitely you want to find out exactly what the family is doing, because we believe that those everyday skincare practices can impact the infant skin. So these are some of the statements that after climbing through the literature that we were able to agree upon. Excluding culture and ethnicity restricts our overall understanding of health research evidence. Number 2 statement that we all agreed on, genetic and environmental factors influence the stratum corneum, barrier properties, and function. Also, literature suggests that racial and ethnic variations in ceramide content, stratum corneum structure, and filaggrum mutations do exist. In all ethnicities, regardless of skin tone, newborn and infant skin has an elevated transepidermal water loss. It is more alkaline if you were to check the pH of the skin surface. It has increased desquamation, which Dr. Schachner pointed out. And it may be, these things may make it more susceptible for our infants and newborns to have infections, impacts from chemicals, as well as thermal damage to the skin. But in general, and I'll break down the last statement a little further in the next slide. In general, skincare for neonates and infants should be safe, promote a healthy skin barrier. Definitely you want to be light on the fragrance. You want to be sensitizing free, pleasant to use, and really contain ingredients that complement that skin barrier, the natural physiology of the skin, in both lipid and water content, especially in the stratum corneum. And an example of a product that can do that would be one that was emphasizing and contained ceramides. So that was a big conclusion statement that, based upon the literature, we were able to agree upon. Oops, I want to go back to one slide. Oops, I'm going forward instead of backwards. Roxanne, can you help me go back?
There we go.
Thank you. There we go. Thank you so much. So more from our conclusion statements, we're really trying to bring the point home that talking to your patients about their cultural practices is very, very important, regardless of skin tone, because those practices can definitely, the more we know about them, can help us to help our patients be more adherent into our regimens. And really what I like to teach is that not necessarily the patient's more adherent is the issue, that we have to do what we need to do and find out so that we can weave our suggestions into their cultural practices so that we can approach this as a team and a partnership. Okay, so definitely some take-home messages about education. there is definitely a need to consider some of these unique characteristics of the skin that we've talked about, and having over-the-counter products that can target some of the things that we've learned about some racial and ethnic differences in infant skin can be helpful, and may even do things like help with sensitivity and help with patients who are more prone to irritation of the skin. Skin barrier disruptions like those observed in atopic dermatitis skin may benefit from a ceramide containing cleanser and moisturizer. This is a final study that I want to highlight. Randomized controlled trial evaluating a baby wash product on skin barrier function in healthy term neonates. So this study took patients, enrolled them in the study. One group was instructed to cleanse their skin just with plain water, and the other group was instructed to use a special wash designed for infant skin. And these were some of the things that they found. So just talking first, let me talk about the actual wash that they used. So the wash that they used really took into account that the neonate should have a pH of around 5.5 on the skin. And so they were able to use a cleanser that kept that in mind. But what they found is that they did not find a difference in transepidermal water loss between the group that cleansed with a special cleanser and the group that used a water-based cleanser. The results of these were actually replicated in a smaller trial and also a bigger trial. So a moisturizer use in newborns is an acceptable practice, and we believe that it is beneficial for the skin. However, the thing about the cleanser part, we still have questions surrounding that. So we do need some more data and research. But based upon the pilot study that I just highlighted, they really didn't find a difference in transepidermal water loss with the patients who were using the special cleanser and those who were not. So we definitely need more studies. But what the take-home message is from this is that these studies do offer some reassurance that parents who would like to use a special cleanser that is especially made for infant skin should not have to worry about it being more irritating or more damaging than just plain water alone. So I hope that you found some of these takeaway messages from these few studies helpful, and I would like to turn over the floor to Dr. Heather Willery-Lloyd.
Hello, everyone. I am happy to be here tonight or in the morning, depending on where you are, to talk about skincare in infants and newborns in our skin of color population. So this is our first quick poll. Do you think skincare is important in newborn and infant skin health? Do you think it's not important, somewhat important, or very important? And so I'm very curious to see what people think about how important skincare is in newborns and infant skin health. So let's see what all of you think. And I don't want to be biased, but I think it's important. That's what I'm going to be talking about today. So let's see what we have here. So 83% of you felt that it was very important, and I agree. So let's look at some research on that. So first we're going to start talking about, I'm going to talk a little bit about moisturizers and ceramides and skin of color newborns and infants. That's what I'm talking about tonight. And there are definitely racial ethnic variations in the skin barrier. And last year, we really delved into this. And this is a paper that was published with myself and my esteemed colleagues looking at the racial ethnic variations in the skin barrier. And this was not particular to children, but just in general in the studies that have been done and their implications in skincare. So what did we find in this paper? In this review, this consensus paper, we see that when you look at all of these articles, there are a few trends that are pretty consistent. So one that is consistent is that there's no difference in skin thickness between Black and white skin, and the first two studies show that. Studies, as Dr. Schachner mentioned, show that there's a weaker barrier and slower recovery from barrier damage in East Asian subjects. In one study, Blacks had increased spontaneous desquamation compared to those with white and Asian skin, and also had higher dryness scores. So our Black patients are more likely to have dry skin, and I do see that clinically, and that has been pretty consistent. And then the last bullet here talks about slower desquamation on the ventral forearm in Black subjects compared to white and East Asian subjects. So let's talk about transepidermal water loss. That's always a hot topic, and you know, there's kind of varying results on this, but we do see that when they look at transepidermal water loss and compare skin strength, these are the findings they found. East Asian and Caucasian women had lower maturation and relatively weak skin barriers when compared to African Americans, who showed higher protein cohesion in the upper layers of the stratum corneum. But interestingly, as Dr. Schachner mentioned earlier, lower ceramide levels. So these findings suggest that our East Asian patients may have increased skin sensitivity, and our Black patients may have higher prevalence of xerosis or dry skin. So this is another table from that paper, but we're going to focus on the ones that were done in children because we're talking about infants and newborns today. And this is talking about specifically atopic dermatitis. And the one thing that I'd say is consistent across the board, every study has shown this, that there's a higher prevalence of atopic dermatitis in Black children compared to white children, higher prevalence of atopic dermatitis and sensitization in Black children compared to white children in the second study. This study was done in the US, again, higher prevalence of atopic dermatitis. And then this very important study in the British Journal of Dermatology showed not only was there higher incidence, but also greater severity of atopic dermatitis in Black children compared to white children. So I think we all see this clinically, but every single paper that has looked at this has really supported this finding. So we know there's some barrier alterations, and those aren't very conclusive, but for sure, atopic dermatitis is much more common in our Black patients and our patients of Asian descent. So let's talk about bathing of newborn infants in ethnic populations. Now, this was a study that looked at 64 full-term newborns in Berlin, and they wanted to test the hypothesis that twice weekly bathing with a commercially available gel wash and cream did not harm the skin. So we just saw some studies on that. And in this study, they either bathed them twice daily with this wash, twice weekly, sorry, with this wash, twice weekly with just clear water, and then applied a moisturizer, twice weekly with the gel wash and applying the moisturizer, or just bathing with clear water alone. So that was one study. Then there was a second study, very similar in the Philippines, that compared two different liquid cleansers with water alone, and that had 60 infants in each arm. So in both studies, they found that the neonatal skin barrier function was not harmed by the tested skincare regimens in healthy full-term infants. So what is that take-home message? That means that skincare certainly didn't hurt, and our patients can feel very confident that using skincare in newborns is not hurting the barrier. There was no difference between skincare and water. And there are, we think, some benefits to using skincare, and we're going to go into that in the a little bit later in this talk. So there is growing evidence and increasing recommendations regarding the benefits of the appropriate use of mild liquid cleansers. What do I mean by that? I mean cleansers that have a low pH, that are close to our acid mantle, that are not irritating, don't have fragrance, non-sensitizing. Those types of products I think are quite beneficial, don't cause any irritation, and have been shown to cleanse and hydrate the skin better than water, and they also help to, they protect the skin because they have some moisturizing properties. So when we think of our skin of color populations, there's a wide range. First of all, the skin of color population, it's a huge range of races and ethnicities, and definitely unique to certain cultures. There's lots of different types of products that are used, and we really don't have enough research to know how the different local cultural product uses influence healthy infant and newborn skin or kids with atopic dermatitis. So we definitely need more research on that area. But there are a few studies that have been published, and this is one out of Bangladesh, 322 subjects, and 96% of the primary care takers applied one or more products to the infant skin with mustard oil. So mustard oil was very popular in this area. And they also did infant massage, which is done, and it was done 2 to 3 times daily. So something that was a part of just healthy infant care was not only applying mustard oil, but also daily massage 2 to 3 times a day. And the reasons why these the parents did this is because they felt it prevented dry skin, it prevented infection, and also improved thermoregulation. So the authors concluded that the time and resources spent on oil massage suggested it was very important in the daily care of neonates in this culture and had a lot of cultural significance. And that's not just unique to that area. There's reports in other countries such as Nepal and Pakistan where oil massage is a universal practice in babies. And a lot of times the parents are using mustard oil, which we would think may have some sensitizing effects, but it's actually well tolerated. And the families reported that they use, although mustard oil is really used for cooking, that they use the best quality mustard oil for the babies. That was saved for the infants and babies. So, you know, it's very interesting how in different cultures, applying an emollient, in this case, oil and massage, was absolutely essential to infant and newborn care. So let's look at some other studies. This is a paper that kind of reviews emollient therapy in newborn skincare in Africa. So this is in Egypt, some of the practices they did in Egypt and in Ghana. But I'm going to take a look at Nigeria because I think it's interesting because they also looked at, if you look over here at the report of palm oil. So they use palm oil in the newborn baby's skin, particularly for babies of low birth weight. And they used it between the folds to prevent body odor. All of these reported using skincare because there was this concept that skincare would prevent body odor later in life. I thought that was quite interesting. But it's very interesting that across the board in many, many cultures, skincare is integral for babies and for newborn care, and particularly emollients are integral because we saw that in, we see that in many of these studies. So this is actually a review of 24 relevant papers from 1,300 sources in Africa. And basically, they argue that emollient therapy potentially offers a simple, cost-effective intervention to improve neonatal survival through the reduction of sepsis. And we haven't talked about that, but there is a strong belief and some data to suggest that obviously if your barrier is intact and you have a great skin barrier as a newborn, you're less likely to get infections. So emollients were really important for preventing infections. And although this is observational, it is really a part of the neonatal care for many, many cultures around the world. And I do think that we can learn from some of these cultures. So let me go back one. Okay, here we go. So this is a different study, and it was done in the UK, and they wanted to see how infant skin changed in the first 4 weeks of life. So parents, they basically surveyed parents on what they did. And parents, of course, were unfamiliar with the process of the natural skin maturation. You know, most parents haven't been educated on the skin barrier. And they were really very anxious about what products to use, but there were questions about what they did. So 33% of parents use oils and 13% use creams and lotions. Those are the most frequently reported products used. But interestingly, when you pulled out BME, and BME stands for Black and Minority Ethnic Populations. So the Black and minority ethnic populations had less hydrated skin at birth, but the most hydrated skin at 4 weeks. And what also was unique to this BME population, the Black minority ethnic populations, that they were more likely to use skincare products than other ethnic backgrounds, and particularly use of oils. So overall, 62% of these parents were more likely to use oil on their infant skin. When you look at the population overall, it was around 33%. So I think that's very interesting, because even though at birth, the minority groups had less hydrated skin, they had the most hydrated skin at 4 weeks, and they were most likely to use emollients on the skin in those 4 weeks. So I think there's something to be learned by this concept of using emollients in infant skin. The study found a significant impact of ethnicity on infant skin. As I mentioned, the Black and minority ethnic groups, those infants did have drier skin at birth, but actually more hydrated skin at 4 weeks. And so, as I mentioned, the ethnic group did not only determine differences in the biophysical nature of the infant skin, but it also shaped the skincare practices and distinguished those ethnic groups from white populations. So we saw earlier today the recommendations from the American Academy of Dermatology, and this is the consensus on the European guidelines for the treatment of atopic eczema, atopic dermatitis in adults and children. And I've reviewed all of the recommendations, consensus statements from different areas. We did that in one of our papers, and all of them do mention moisturizers, regardless of the region. South America, Asia, everyone talks about moisturizers in our atopic dermatitis patients. So this is the European guidelines say that moisturizers should be prescribed in adequate amounts, and these should be used liberally and frequently with a minimum amount of 250 grams per week for adults. Moisturizer, bath oils, and soap substitutes should also be used. Moisturizers with a high lipid content are preferable in the winter, and the regular use of moisturizers has a short and long-term steroid-sparing effect in mild to moderate atopic dermatitis. Now, this is a really important take-home message, because moisturizers alone do improve atopic dermatitis, and I'm going to show you a study on that. So if we want to use less steroids in our atopics, we really do need to emphasize skincare and moisturizer use. So what is the evidence for moisturizers in AD? So we definitely know that moisturizers improve skin barrier function in AD and reduce susceptibility to irritants and possibly infection. Long-term emollient therapy improves AD-associated xerosis. Standalone emollient application may improve mild to moderate AD, and I'm going to show you a study that looks specifically at that. A comparative study showed that a non-prescription moisturizer was as effective as a more expensive barrier cream. Another study in adult AD patients suggested that coconut oil may reduce Staph aureus carriage. So as I mentioned, I keep talking about infection because in other cultures, oils are frequently used to improve the barrier and reduce infection. And the daily use of emollients from birth may significantly reduce the incidence of AD in a high-risk population. And Dr. Schachner talked about those studies in detail. So now I'm going to talk about this study. This is one of the most interesting studies, I think, because it looks at mild to moderate atopic dermatitis patients, and the only intervention was a gentle cleanser and a moisturizer. They did look at children and adults, but of course today we're going to focus on the children, which were under 12 years of age. And this is what the study found. So the demographics in the kids under 12 years of age, they were actually majority boys, 63% boys, 36% female. These were typical atopics who also had associated dairy allergies, hay fever, asthma, and other atopy. They had typical atopic dermatitis in the antecubital fossa and all of the areas that we're very familiar with. And they had all the signs that we see with atopic dermatitis: dry, very dry skin, crusting, oozing. So these were mild to moderate atopic dermatitis patients. And these patients were treated, as I mentioned, with a gentle cleanser and a moisturizer containing ceramides. So we're going to focus on this, the first graph here, on the reduction in very itchy skin and atopic dermatitis symptoms. So you can see this light pink bar. Around 30% of subjects were very itchy at the beginning of the study, and at the end of 42 days, that dropped down to less than 10%. And when you look at the AD symptoms, that's the most important one. You can see the 100% of patients had atopic dermatitis symptoms, and that dropped down to 20% at the end of 42 days. And remember, this was just monotherapy with a gentle cleanser and an emollient. So that's a huge improvement. Now, when you look at this one here, you can see I'm going to focus on quality of life, and the things that I think affect quality of life the most are itch, pain, and irritation. So you can see that the itch score dropped dramatically from day 0 to day 42. Painful, so their atopic dermatitis became less painful and also less irritating at the end of 42 days. So obviously, this is not saying don't use steroids or anti-inflammatories in our atopic dermatitis patients, but what it is saying is that skincare alone really can make a huge impact on our patients. So in conclusion, understanding the differences in the functional properties of infant skin across races and ethnicities, and discussing and recommending skincare products and routines to parents of babies with skin of color can improve newborn and infant skin health, keeping in mind the cultural practices of those patients when you're talking to your skin of color patients. So now this concludes the presentation, and we're ready to get some questions and answers, and we can get started with those now.
So again, if you want to submit a question to our faculty, use the question chat pane on the right-hand side of your screen. And if you think of any questions after the webinar, please send them to info@rbcconsultants.com and we will forward them to our faculty. We'd like to thank again our sponsor, CeraVe, for making this educational event possible. So we do have a couple of questions from our audience. If you do not recommend soap, what do you recommend for cleansing in babies of skin of color?
So I can start with that. I'd love to hear everybody's answer, but I would say we want a gentle cleanser that's non-sensitizing. So the word soap to me implies a traditional soap, like a bar soap that's typically alkaline. But there are specialized cleansers that are safe and effective in babies that are very gentle. So it's pH balance, meaning the pH matches the acidic, a lower pH product, less sensitizing, no fragrances, no irritating ingredients. That's the type of cleanser that I would recommend for babies. But I'm curious to hear what Dr. Heath and Dr. Schachner say.
Yeah, I totally agree. I totally agree with you.
What they said.
Do we know how high the prevalence of AD is in South Asian, Middle Eastern, and Latino babies?
So that's a great question. I think that we don't have, so when we look at these studies, you probably notice in that data, it always has Black, white, East Asian. That's it, every single study. I know there are some studies out there. I don't know them off the top of my head, but I definitely see a huge dearth of information for Southeast Asian patients when it comes to atopic dermatitis. So I don't know those off the top of my head. And unfortunately, all of the studies just look at Black, East Asian, most of the prominent studies look at Black, East Asian, and Caucasian.
I might add that no matter what study I look at, what part of the world, we seem to come in at 20 to 25% of kids are atopic. Anywhere where there's industrialization, anywhere where there's heavy population density and manufacturing. There are some studies that would suggest that if people move from the farm to the city, that they are more likely in the city, if you compare a like number of infants and children, more likely in the city to develop atopic dermatitis. But almost all the studies I've seen are in the 20-25% range.
At what age do we stop applying emollients to infant children on a regular basis?
Fine. My answer is never. I know if atopic or even if a healthy skin, emollients are just good for the skin and for the functions. Dr. Ulrich Lloyd mentioned a number of them. Another question I get, instead of quantity of time, sometimes parents say, is there any particular risk in putting too much emollient on? And the joke I always say is, if you hug your baby and they fly up to the ceiling, you're probably overdoing it a little bit. And in fact, babies can get a little slippery, so you don't want to overdo it. But both the reapplication, we saw some populations do 2 to 3 times a day with massaging, and it just has been very effective, even in the United States. There's studies on massage therapy using emollients. There's no end date for me.
Right.
I agree.
I need an atopic. Once an atopic, always an atopic.
I
Emollient
agree.
will attenuate. So I think we have a consensus.
Mhm. Is oil recommended in infants? Any concerns about aspiration?
Of course, I think that's definitely a concern. And Dr. Willory Lord did present some very nice data about how oils can be beneficial. But yes, they can be used safely, but there are a lot of caveats to that. People are using essential oils and things that have lots of things in them that could potentially irritate the skin. So you go from having a cultural practice that has been, as Dr. Willory Lord talked about, purified and the best oil, to just all oil is not created equal. So I'll pass the baton to her because the answer is it's complicated. It
Right,
depends.
I agree. I think I like to even the playing field in my patients, so I want to know what they're using. So I usually recommend a specific product because then I can predict the results. Definitely patients will ask about what oils can they use, but I prefer and kind of direct my patients to products that I know that have been shown in studies to improve eczema, that are safe, don't have sensitizing ingredients, don't have fragrance, and so forth. And definitely I tell every patient no essential oils. I really do emphasize that.
Is there any data on leaving vernix on and its effect on AD later on in childhood?
Well, I guess I brought up vernix, so I am not aware of any study looking at long-term benefits. I am aware of short-term benefits, and key among them is to help create what Dr. Willory Lloyd called the acid mantle, a desirable pH somewhere in the mid-4s to 6, and also to increase the rate of colonization of commensal bacteria that we need on our skin, and also holding off pathogens to a degree. But I'm not familiar with any long-term follow-up. My fellow panelists have some information. I welcome it.
No.
In what disorders do you see decreased ceramides in skin of color patients?
Well, eczema would probably be the top of that list. I think that across the board, every study I've ever seen has shown that patients with black patients are much more likely to have atopic dermatitis, not only more likely to have it, more likely to see the doctor more frequently for it and have more severe disease, all three of those things. So we don't know if it's a causal thing, but it appears to be the black, and again, in 3 studies, there are 3 studies that show that black subjects had lower rates of ceramides compared to other ethnicities. Now, we can't say cause and effect, but definitely atopic dermatitis would be the big one.
Mm-hmm. And even kids who don't have atopic dermatitis, if you biopsy them, you would also on average find lower ceramides.
Mm-hmm.
So there's work to be done there as well.
In normal skin.
Mm-hmm.
Then if you want to call xerosis a diagnosis, then I would say it's likely that low ceramides also correlates with xerosis. That's likely.
And
I believe that is.
and I would also add certain ichthyotic conditions, certain disorders, even ichthyosis vulgaris can have decreased ceramides. And people are looking at this issue more now. And I've seen some literature talk about acne, talk about psoriasis. So there is a number of areas to look at in terms of the role of ceramides and the need for them in some of the inflammatory disorders we treat.
That's a very good point. I think almost all of our inflammatory diseases in dermatology have a barrier problem. Obviously, atopic does, but acne does, psoriasis does, and rosacea does also.
Yes.
Do you apply moisturizer before or after topical steroids for atopic dermatitis?
Who wants to go first?
I tell people to apply it after they apply their medication. So medications go on the hot spots or the areas that are flared, and then your moisturizer is going to go all over the skin.
Yeah, I agree. I'd give the exact instructions.
And how do you address PIH in darker skin atopic patients?
Sorry, you went mute
Oh.
for
How do you address PIH in darker skin atopic patients?
Okay, how do you address PIH? So that's a very complicated issue, because most of our agents to treat hyperpigmentation are irritating and drying, and it can be, you know, the patient's really concerned about the hyperpigmented dark plaques, but they also have active atopic dermatitis. So I've seen two approaches. What I personally do is I clear the atopics first, so I make sure that their skin is calm, the inflammation is quiet, and then I do azelaic acid mixed with triamcinolone. Usually this is on the legs. That's what patients will complain of, on the legs. So I'll mix a little azelaic acid, equal amounts, and they can use the triamcinolone ointment, and I've seen good results. But I was on a panel recently, and that other physician actually adds hydroquinone to clobetasol, so has a compound that has hydroquinone and clobetasol and uses that approach. So there are a few approaches. I'd be interested to hear what everybody else does.
So I would say that would be a great subject for our next webinar.
Yeah.
Really approaches, and so much culturally and ethnic sensitivity in the areas of hyper and also depigmentation. As you said, it's extraordinarily complex. I think you've mentioned the two tools, you know, that we primarily think about in terms of hydroquinone and azelaic acid. There may be some others, but I think those are the ones we're most comfortable with because we've used them. And then everybody has their formula. There was an original formula with hydroquinone, steroids, retinoids, others have done, as you've said, personal taste, but that is an extraordinary subject for an entire webinar. Candace, any pearls?
I like to, other than what has been mentioned, I like to really treat the atopic dermatitis aggressively. So if the pigmentation is diffuse, several locations, I question to think, okay, do I really have good control over the atopic dermatitis? Are these areas still itchy? You know, there have been studies done that even biopsying skin that you don't think is really involved, in the atopic dermatitis, they look, and, you know, I think this was studies from Emma Gutman, and they still saw active atopic dermatitis in skin that appeared normal, or just looked like it was, you know, post-inflammatory. So with that, I definitely treat systemically for atopic dermatitis in those patients. And if it truly is just post-inflammatory hyperpigmentation, yes, I really typically would do a single ingredient hydroquinone in a very motivated patient, typically, you know, high schoolers, prom is coming up, things like that. Because yes, it is a very fine balance between inflaming the skin and making that PIH worse, and even flaring the atopic dermatitis. So it has to really be done in a candidate that you can really partner with to make sure that they will stop if there's irritation.
Well, that's all the time we have together this evening, but we'd like to thank our faculty for such an insightful presentation and also your expertise in covering a topic that's pretty broad. And we'd like to thank all of you for joining us this evening. Please join us again on October 11th when we'll be covering with Dr. Robert Kirshner and Shasha Hugh a new published diabetic skin algorithm. Good night, everybody.
I do.
Good night.